Hi, good evening, everybody. So ECMO, as I said, has been at the forefront since the pandemic. Firstly, we should understand what ECMO is, because when we think about ECMO, we have these visuals of giant pipes sticking out of patients' legs and necks connected to some big machine. So basically, ECMO is an extracorporeal therapy wherein you take the blood out, run it through a machine, and then send it back to the patient for prolonged respiratory or cardiac support. So basically, it can be used as a bridge to recovery. So if a patient has a reversible injury, it provides support till the patient's lung or the heart recovers. It can be a bridge to transplant. So if a patient has irreversibly damaged lungs or heart, it can be used in the interim while he or she is waiting for a transplant of the organ. It can be a bridge to decision. So if the patient is in an emergency and goes on to ECMO, it gives you time, it gives family time to come up with a decision as to what to do next. Instead of being a decision to be taken within minutes or hours, it gives you days. And also as a bridge to mechanical support, this is specifically for cardiac support. So patients who are having severe cardiac failure but are not candidates for transplant, they can go on to an ECMO and then have time to put an LVAD or an RVAD or a BiVAD put in. VAD is a ventricular assist device for cardiac support. So just a brief history of ECMO. ECMO starts the starting point of ECMO is the cardiac bypass machine. So basically, the aim always was to do a bypass. Normally in the OT, it is done for a few minutes to probably an hour, but to stretch this out for a few days was the challenge to be overcome for these patients, because bypass needs a very high amount of anticoagulation, and the longer you are on that kind of an anticoagulation, the higher the chances are of bleeding. The other major challenge was to get the oxygenator technology to work. So initially you had what is called as bubble oxygenators, and then you had silicon membrane oxygenators, but they would not function probably for maybe a couple of days at maximum. The revolution came upon when we had the hollow fiber oxygenators come in, and we'll talk about that a little later. And then these experiments with hollow fiber oxygenators were being done on animals. And essentially in California, there was a Spanish immigrant, an illegal immigrant, who had a baby outside the hospital, and this baby had a meconium aspiration syndrome. So basically, because she couldn't access healthcare, this baby was basically left at the hospital, where fortunately these experiments were going on how to provide respiratory support. So essentially, Dr. Bartlett, if you can see over here, basically put the machine, which was basically designed for animals, on this young kid, maybe a day old. And this patient survived. This was the first human ECMO to survive. And because this girl was abandoned by her parents, the sisters of the hospital named her as Esperanza, which means hope in English. It's a Spanish word, it's a Spanish name, and it means hope in English. And this is the girl who grew up to be an adult. And that basically started the revolution of ECMO. And it's always been shown to be very, very effective in kids, and adults it later picked up. So what are the indications for ECMO? Now, we'll come on to what VV and VA ECMO means in a couple of minutes, but VV ECMO is basically for respiratory support. So a patient who has ARDS due to pneumonia, or a viral or bacterial, patient who's awaiting lung transplant, trauma causing lung contusions where gas exchange doesn't happen, or sometimes pulmonary embolism as well. Also VA ECMO, which is basically for cardiac support. So for cardiogenic shock of any cause, post cardiac surgery, if a patient is difficult to wean off bypass, or patients who've had a myocardial infarction and have had a stent in place, but despite establishing flow, there is poor cardiac function, so they require cardiac support for a couple of days. Another newer indication is drug overdose from cardiac toxins, so beta blocker overdose or calcium channel overdose. You can put them on ECMO. Myocarditis, so whether it is viral myocarditis or autoimmune myocarditis, this can be tried. can also be tried as a bridge to transplant. And the upcoming thing is what is called as eCPR or extracorporeal CPR, where normal chest compressions and shocks are not able to revive a patient. And then you put these patients on VA ECMO to give you time to kind of correct the cause of the cardiac arrest. What does the nomenclature mean? So basically, when we say VV ECMO or VA ECMO, it shows you where the drainage is. So basically, you have blood coming out of the body, going through the machine and going back into the body. So the two letters basically show you what is the vessel which is being drained and what is the vessel which the blood is being returned into. So VV essentially means that the blood is being drained from one major vein and being put back into another major vein. And this is for respiratory support. When we talk about VA ECMO, the blood is being drained from a vein and then it is put back into an artery of some sort, usually the femoral artery when we do an ECMO peripherally. Other than this, so you have ECMOs being put on one patient and something called a VVA ECMO or a VAV ECMO. These are slightly more complicated. So we're just going to leave it, but it's essential to know. So what is the evidence for ECMO? There are two major trials which were done in ECMO. The first was the CESAR trial, which was done just before the H1N1 swine flu pandemic in the UK, which was the first trial to show mortality benefit in adults in ECMO with severe respiratory failure. Kids always had a good outcome for ECMO, and it has been an established modality for treatment of respiratory failure, especially for meconium aspiration syndromes with very good outcomes. But adults, we didn't have much success until the CESAR trial. And the latest one is the EOLIA trial, which was done in 2018. That did not show much mortality benefit, but there were problems with the trial design. But the established fact right now is that if you have severe respiratory failure and if an ECMO is done at a center which has good experience with ECMO, your chances of survival are very, very high.